As many of us know, perilunate injuries are due to high energy traumatic events, often falls from height, motor vehicle accidents, or skateboard injuries, as we see a lot around here. Wrist injuries in general account for about 2.5% of all ED visits, and 5 to 7% of those are carpal injuries, such as perilunates. 25% of these are missed, so 1 in 4 are missed injuries, and so it's really important, like Dr. Vogeli was saying, to make sure that you have a high index of suspicion for these when they come into your office and they're still having pain. 10% of these are open injuries, often secondary to the high energy traumatic event. 26% are associated with polytrauma, and about a quarter to half have acute median nerve symptoms, which is something that we worry about as hand surgeons. For perilunate versus lunate dislocations, 97%, so the vast majority, are dorsal, and about 3% are volar dislocations. And the questions I often ask our residents are, what exactly is the difference between a perilunate and a lunate dislocation? So a perilunate is where the carpus itself dislocates dorsally, but the lunate remains intact in line with the distal radius. A lunate dislocation is the last stage of the Mayfield Classification, which we'll go through in a few seconds, and that is where the lunate itself actually dislocates volarly into the space of Poirier. I'm sure you remember that from residency, good times. Transcaphoid perilunates, as well as other fractured dislocations, can occur, and that occurs in about 61% of all of these injuries. So this image here shows a very nice lunate dislocation where the lunate itself is very volar, very proximal, within the carpal tunnel. And in general, we always talk about Galula's lines. So there's also the greater and the lesser arc of injuries that we talk about. Greater arc injuries include bony injuries, so scaphoid, capitate, distal radius. Lesser arc injuries are going to include ligaments only, and I'm not going to bore you with all the dorsal ligaments and all that fun stuff today. But there are 3 Galula's lines, and so when you're looking at radiology imaging of these injuries, you want to make sure that you're assessing and ensuring that the Galula's lines are intact. The most proximal is that of the proximal row. It then goes to the blue line that you can see there, which is the distal aspect of the proximal row. And the red line is the third Galula's lines, which is the proximal aspect of the distal row. In terms of the Mayfield Classification, this is how we determine how severe the injury is. And it goes in a circumferential type of injury pattern. The first of which is the SL, which gets disrupted, the scapholunate ligament. The second of which is the lunocapitate joint, capital lunate joint, The third of which is going to be the lunotriquetral ligament, and that is where you get the dissociation of the carpus dorsally, and the lunate stays intact in line with the distal radius. And then stage 4 is the full lunate dislocation, where the carpus then reduces back in line with the distal radius, and the lunate falls volarly. So on standard imaging, we often talk about the teacup sign, which you can see here nicely depicted, where the lunate is actually tilting volarly. And then the piece of pie sign, or the pizza pie sign, depending on which coast you're at. And this is where the lunate is basically flexed volarly, and so you're gonna see more of the type of triangular disruption there. In terms of basic diagnosis and imaging studies, standard radiographs, PAs, and laterals are very much sufficient in order to make a diagnosis. I often ask for CT imaging, but only after we do a closed reduction. So it's not as useful as you can see here because it doesn't really tell you a whole lot. You know the lunate's dislocated based on the x-rays alone. But CT imaging can be helpful in preoperative planning to assess for any occult fractures of the scaphoid or distal radius. In terms of initial management, we want to get these closed reduced very quickly. These are very pertinent to be done fast in the emergency room, as oftentimes they come in with acute carpal tunnel syndrome. I often ask the residents, or if I'm doing this, which is rare, to have the patient have conscious sedation because then you're not worried about a hematoma block affecting the acute median nerve injury as well. In terms of examining the patient before and after the reduction, it's extremely important to assess if the acute carpal tunnel injury has changed. If they have, am I not talking loud enough? I feel like I'm really loud, so thank you, Ted. So in terms of acute carpal tunnel, you want to ensure that they have resolution of their symptoms. If they do not have resolution of their symptoms, then you want to admit them overnight and do this urgently. If they do have resolution of their carpal tunnel symptoms, you can discharge them home if their reduction is maintained. In terms of approach for these perilunate injuries, we look at volar, dorsal, or combined approaches. Volar approach can be done through an extended carpal tunnel. Oftentimes you're going to be doing a carpal tunnel release on these patients already. So doing an extended carpal tunnel release in addition, and basically looking at the volar ligamentous structures, and you can do a primary repair at that time. Also, if you're having trouble reducing the lunate, you can use the volar approach to access the lunate and get it reduced. You always want to make sure the ulnar limb of your incision is ulnar because you want to avoid the palmar cutaneous branch. In terms of the dorsal approach, I usually make that in line with the third ray, and I put that just ulnar to Lister's tubercle. And when I transpose the EPL at the beginning of the procedure, I go down to the capsule itself, and then you can do either a ligament sparing approach, which is through the DRC and the DIC, which is the dorsal radiocarpal and dorsal intercarpal ligaments, or oftentimes in perilunate injuries, there's always a rent or some type of laceration within your capsule itself, and you can utilize that in your capsulotomy as well. And then in terms of fracture fixation, you often want to fix the fractures first. For instance, in this picture here, which was a very, very unstable transstyloid perilunate / radiocarpal dislocation, she did not have a disruption of her SL because the scaphoid itself was fractured. And so when it goes through that greater arc, you get a fracture of the scaphoid and not necessarily involvement of the SL ligament itself. Ultimately, your goal is to make sure that the lunate is in neutral. That is the pearl, that is the most important part of this operative sequence. You want to make sure that your fracture is fixed because, like I said, that can increase your stability and make the rest of your fixation and pinning of the carpus easier. I pin SL, LT, and SC, although some people do not pin SC. I pin the scaphocapitate joint because I think it helps with flexion of the scaphoid itself. And then ultimately, you want to repair the SL ligament. So when I'm preparing for these cases, if I'm doing fracture fixation, I do the headless compression screws. I have K-wires, 4, 5, and 6, 2 K-wires, and then I often have little small joint anchor that have usually a 4-0 ethibond so that I can repair any ligaments with a horizontal mattress as needed. In terms of outcomes, we often see these have not the best prognosis. Those that have poorer prognosis are those with open injuries, delayed treatment, or osteochondral fractures of the capitate because they're more likely to go on to arthritis, as are those with persistent carpal malalignment. Patients who have improved outcomes are those that have early reduction and stable fixation with appropriate ligament fixation. In terms of how to counsel patients preoperatively, it's really vital to tell patients they're going to lose range of motion. The injury in and of itself is extremely traumatic, and they'll lose about 30 to 40, 50% of their motion. So what they've shown in retrospective reviews of case series is that patients get back 60 to 70% of their contralateral side. Their grip strength is also decreased to about 70 to 80% of their contralateral side. The vast, vast, vast majority of these patients do get post-traumatic arthritis, and that can be mid-carpal and or radiocarpal arthritis. And most patients are able to return to their occupation. So this is a nice review of a few case series, and you can see that, again, most patients get back a good amount of motion, but it's never going to be perfect. The grip strength does decrease, which is important, especially in patients who are laborers and where they need to really have that grip strength. And there was one study by Soterianos et al. That showed that only 50% of their patients went back to work, but others show that the vast majority of patients do go back to work. Thank you.